This panel will be a little bit different than most of what you've heard today so far, because this one is going to be using a financial lens and talking about investing and moving capital into the space. So just for context, here in the United States, we spend nearly 20% of GDP on healthcare. And as an investor, if I was thinking, well, what's my return on that investment? We at the same time have life expectancy here in the States at a 2-decade low. Infant and maternal mortality are rising. And we have a number of diseases which remain chronically underfunded. At the same time, we're hoping to invest in promising technologies and companies in the advent of AI and all the opportunities that might portend for us. But we're also, from an investor perspective, facing troubling waters with rising interest rates. We've had supply shortages, and there's geopolitical tensions we need to navigate all the time. So with that as a backdrop, I think I'm going to start with Adaeze. So you have a unique perspective because you have actually worked inside the government, which sets policy, and now you work at a private equity firm as well. So tell us, let's use your first lens, or let's contrast the two. When you think about working at OMB and being responsible for a $1 trillion budget, what are some of the agility factors and nimbleness that you see in the private equity space that the government can learn from? And what kind of scaling impact does the government have that we can put into a business context?
That's a great question. Thank you, Richard. And thanks very much to the Milken Institute for assembling this panel and facilitating this important conversation. It's almost unfair to compare what you can do in a private equity or private sector space to what to the scale of what you have to, what you confront from a federal government perspective. So just to provide a little bit more context, at OMB, I had Ebola, I had Zika, I had lead poisoning in Flint, just in terms of the first order, not personally, by the way, first order public health crises. And then you have all of the payment rules that will come out of the Centers for Medicare and Medicaid Services, so CMS, getting CMMI off the ground. I think I did 8 models in 1 year. If you just think about just the sheer scale and size of that. And in every instance, you're thinking, not just domestically in some cases, but actually globally. Zika, for example, is a global issue, as was Ebola, though I had the tail end of that. In private, by definition, nimbleness can be hard, even though we had to be whenever we could. In responding to a public health crisis, you have to assemble all the major actors immediately, but you have the convening power. You have, just by definition of being in the White House, you can bring those people, and they do want to play. If it's, investors, as we're looking through BARDA, my portfolio was ridiculous, really, when I pause and think about it. It's not a job for one person, but it is in government because that's the way it is in government. On the investment side, in the private sector, you have some room to think about and certainly to convene and to have conversations around scaling. But it is still pretty circumscribed. One is no firm, not even Welsh, can sort of assemble the world, in service to a particular theme or thesis or company. We, by definition, can bring interested parties, whether they're health systems, if you're thinking about a tuck-in, an M&A strategy with tuck-ins, you can bring some of those parties together. But you're still talking about a pretty circumscribed list of firms that you can bring to the table. But generally, we're talking about a particular company, a particular thesis, and it's very specific. So the government, because of its mandate, has to think about scale you have to think about the census. You're not dealing in samples for the most part. And I think to be useful as an investment firm, you can't think about the world. Your TAM is never really the world. It's going to be a pretty defined addressable market, addressable customer base, addressable potential buyers if you think about your exit strategy. And so you have to be very specific. You can pull from both, but they are different because of just, they're different.
Yeah, okay. So let's stay with the governmentally sponsored organizations. Mohamed, let's go to you. You are representing a sovereign wealth fund.
Yep.
So in Qatar. Tell us, what role does healthcare investing play in a sovereign wealth fund? How are you thinking about it, not only from the return perspective, but also for the health of your population? Some of the investments you make can actually yield not only financial returns, but actually longevity returns as well.
Yep, of course. Thank you, Richard Paulson. Of course, it's a pleasure to be here with you guys, and thank you, of course, for the Milken Institute for organizing such a great conference. The way I would say about it is that the sovereign wealth fund of Qatar is essentially the saving account. So Qatar is an oil and gas-based economy. Last year we hosted the World Cup. I hope you guys got a chance to view it and enjoy it. We're very proud of it, of course. Our roles primarily as a savings account is to invest for the long-term prosperity of the country. And prosperity and health, I think, is something that go very much hand in hand. And the philosophy that we approach in healthcare investing is the core foundation of the philosophy of investing for QIR for the long term, is that we try to identify businesses that provide value to societies over the long term. And these businesses, in our opinion, are the businesses that should thrive and survive over the long term. And the two foundations in healthcare that we try to focus on is identifying areas of significant unmet medical need and how to deliver it in the lowest cost setting. And these two approaches, we think, are crucial for healthcare. And it's a question of affordability. It's a question of disease and suffering and how we can limit these things in society. So, of course, there's certain diseases like diabetes and certain forms of orphan diseases are more endemic in Qatar than the rest of the world. And of course, whenever we find these opportunities that we can deploy capital to help solve the problems, it will be solving Qatar problems as well as global problems elsewhere. And of course, as we try to approach this is kind of like we invest across the world, understanding the local regulations, how societies deal with these things. As I usually say to my investment committee, investing in healthcare, you're investing in a politically sensitive topic that poses a lot of moral questions. And as we go across the world, each society answers these questions in a very different form. And I think our role is to sit down with each society, try to understand how do they want to address these problems, how do they want to face it and tackle it, and potentially provide our capital in the best form possible to enable to resolve these situations. And at the end of the day, it's a very human thing. And it's a big problem for all humanity, and how to address it is unique to each society, but at the very same time, solutions can be taken across the globe in different forms. And that's what excites us, and hopefully we can provide value with that.
Okay. So I want to pick up on what you said about unmet needs. That reminds me of access. Merrill, I want to go to you because I know that 25 Madison Health is doing a bit in rural communities. So for those that don't know, 1 in 5 Americans that live in rural communities do not have access to basic health care. Tell us, what are you doing in that space, and why is it an attractive investment opportunity to do so?
Absolutely. Thank you for having me here. Quickly on 25M Health. So we are a venture studio, which means that we invest not just capital like a traditional venture firm, but we invest time and effort in building businesses together with our partners. Our philosophy is that kind of the scarce resource today in the digital health ecosystem is effective partnership between new companies, which are looking to get off the ground, and incumbents, which can play a really big role in making that next generation of companies successful. And I think in no place is that more true than in the rural healthcare environment, which is a frankly difficult operating environment today. There are a number of pressures that are facing rural healthcare providers. I don't think they're extremely dissimilar to what the rest of the country is facing, but they're just more pronounced there. There's difficulties attracting and retaining talented providers. Rural healthcare providers need to pay more to doctors to get them to come to their community. They need to serve as that tentpole to get independent specialists to move there to provide care, and they need to pay to facilitate that. They have issues not just at the top of the credential spectrum with talented specialists, but all the way down, going from nurses to administrative staff. and pulling those people into the community to make sure that care is available is a difficult challenge in this economic environment. Another thing which is somewhat unique in the rural healthcare environment is that, especially with our partner LifePoint, in many of the communities that they are present in, they are the only care provider for people in those communities. And if the LifePoint facilities do not operate, or if they do not offer a certain service line, individuals have to travel 2.5 hours to receive care at the next set of care. And that leads to worse outcomes and just more difficult experiences for the people in those communities. So a lot of what we do is try to expand access to certain types of care by bringing technology to make that care delivery a little bit more affordable. To provide specific examples of ways we do that, one business that we've helped build in partnership with LifePoint is focused on nutritional therapy. And I know this is a big theme right now with the emergence of GLP-1s, but even with GLP-1s, I was in one of the obesity sessions earlier, there's going to be a lot of need for wraparound consulting to get people, to keep people from going on the drugs who don't necessarily need it yet, and to help people get off the drugs on the tail end of it. And we've built a solution with LifePoint, which helps people in those communities access remote nutritional therapy more easily. So that's one example of something we're doing with the communities there. But rural providers right now need innovation more than anyone because they're dealing with tough operating margins, and they maybe don't have the capacity to invest internally in building some of these new technologies, but they're very willing to partner when the technology is built in a way which is relevant to them.
Mm-hmm. Okay. So Eddie, I'd like to bring you in. Just for the audience's sake that might not be as familiar with some of the financial terms that we use all the time, I know that you have something called Pear X, which is helping the earliest stage. Talk to us about like what you're doing for pre-seed companies, how you find the talented ones to kind of push to scale, and like what's the receptivity today given all the financial pressures in the space?
Yeah, great question, and thanks so much for having me. It's my first some Future of Health Summit, so wonderful to be part of the discussion here. So I can say a little bit more about Pear and Pear X. So some ways similar to Merrill, we're an early stage investor that's very hands-on with our founders. We primarily invest in pre-seed and seed. We're generalists that cover all areas, and I cover biotech, and we also cover healthcare as well in our firm. And the types of founders that we see, they truly are starting at zero. So many of these founders, they may be technically very strong. They may be a recently graduated PhD or postdoc from Stanford or an MIT or another great school. They may be at the forefront of that particular science that they're working on, but they need a lot of help in terms of they've developed the platform technology, and they don't know the market, they don't know kind of what the right roadmap should be to de-risk it and get it funded and find the right partners to take that forward. So where Pear steps in is we try to be kind of like a one-stop shop at these early stages. We have a large platform team that works in concert with our founders on things like refining the story, coming up with a business plan, leveraging some of our own network in terms of advisors who have been there, done that, and are a few steps ahead of these founders. In terms of where we find them, it often is kind of at these top tier research institutions where again these founders have been working for many years in the lab to come up with a new tech. It could be in some cases we invest quite a bit in new enabling technologies for cell and gene therapies. We have a company that's working on our RNA sensor platform to try to make these therapies safer and more effective. So there's so many use cases for that platform tech, and to be able to pair these founders with the right folks in the industry and to work in concert with them, we really see kind of the progression rapidly into being ready for the next stage. And in terms of the macro environment, it's certainly I cover biotech. We had a big peak of interest, a lot of a bubble kind of during COVID. Everyone was obviously extremely impressed by the power of biotech working with government and and industry and pharma to get these vaccines out. And again, investors were really high on, retail investors were really high on biotech. That's obviously kind of crashed. There's a bit of doom and gloom with the public markets, and interest rates, definitely weigh heavily on that. But at the early stages, we're looking at companies that are 6-7 years out from an exit, maybe 10 years out from the market. So in many ways, it's kind of the oscillations of what's going on in the macro and the public is dampened, and the pace of innovation is always there as long as there's research funding to make new advances in these technologies.
Okay. So, Mike, let's start there. Like, given that there is a lot of excitement around technology and its impact, there's wonderful things being done across a spectrum of diseases. We did just put vaccines in billions of arms, relatively short time. How do you think about the negativity that's infecting the space now, right? I think that, is it a miss on the public's perspective? Is there more optimism that should be entering people's thought process, particularly around AI and the like, which has had a relatively modest impact so far in healthcare? But what are you thinking as a healthcare guy in the space around what the future might look like?
Okay, I think that there's a natural tendency to take a shorter term view as to the health of either private capital markets, public capital markets, levels of strategic activity, relative to what I think we're well characterized as a pretty recent exuberant period in 2020 and 2021. I think if you step back and take a more longitudinal view and say, over time, over 5, 10, 15, 20 years, what does that capital formation look like in healthcare, within healthcare technology? What has been the level of strategic interest from larger incumbents in acquiring, integrating, and adding capabilities that are more disruptive and innovative? I think there should be a tremendous amount of enthusiasm and excitement. I think where folks in the public narrative is focused around, look, it's harder to get companies public, it's harder to raise capital. That sentiment is to a certain degree true relative to recent times. But if you go back farther, I think we still see an incredible amount of investor interest. And there may be more sensitivity around things like valuation, structures that find their way into certain types of deals and certain type of capital raising. But if you're a founder of a business and you've worked with a partner over a long period of time to build something that is differentiated and you can prove that differentiation, what we see in our day-to-day, talking to clients and talking to investors, is there will always be a level of interest from the private capital markets. There will always be a level of interest in the public equity markets. It's just a matter of proving the business model, validating the differentiation that you're articulating with data, and making sure that you have reasonable expectations relative to the market backdrop that you're operating with.
And there had been some expectation that the back half of this year might be great for IPOs. That doesn't seem to have materialized. If not that, as an exit strategy for some of these wonderful companies that are being incubated, what?
Yeah, sure. I think that there was a lot of optimism that the back half of 2023 was going to be the return of the IPO window. I think a lot of things played out over the first half of the year relative to the interest rate environment, relative to a few banks that existed on January 1st, no longer existing as of...
Not yours, though.
No, thankfully, Citi still here. I think there are a lot of elements of the fact pattern that evolved. I think stability was a really important indicator above all else. When was volatility in the market going to come down? When was there going to be a level of conviction that the interest rate environment we were in was relatively stable? When you think of the impact that higher rates have on higher growth asset classes, valuations come down as interest rates go up, and understanding where were we going to land from a rate environment perspective so that investors could appropriately price the assets that they were being asked to value. And that the folks who own those assets had conviction that they were in an environment where the price wasn't going to go up or down dramatically after raising capital. I think we saw some stability over the past month and a half, 2 months. We saw more traditional technology companies separate apart from healthcare go public. I think when you look at how those deals have traded, public equity investors have taken a step back as to what that means in terms of the near-term attractiveness of the IPO alternative. So when you think of the knock-on effects of that, stasis typically isn't an option for a corporate. There are dynamic needs of companies, dynamic needs of founders. If you're not going to see that capital in the public equity markets, what are your alternatives? That's private equity. You continue to see an elevated amount of activity among our private equity clients. And you also see an increased attractiveness among our large corporate clients as a potential exit path. So whereas companies had maybe traditionally said the IPO alternative, given the access to that capital, is a really attractive liquidity event for founders, but also a form of growth capital to accelerate the vision, we've seen an evolution in the thought that partnering with a large cap corporate with a really low cost of capital that has a lot of infrastructure and reach might actually help amplify the vision even faster.
Okay.
Rich, if I can just
please.
take one here. So I think one of the key things that when we're thinking specifically about healthcare, because healthcare is a highly regulated sector across the world, and it's something very important to reflect on, because how regulations are unfolding and how it's balancing the economics in the space really has tremendous impact on how the capital is flowing. And when I say regulations, it's regulations in terms of the payer-provider relationship. It's regulations in terms of reimbursements for drugs, as well as regulations return in terms of approvability and FDA actions and all these things. So when you put all these things together, definitely the environment has seen some, I would say, struggles over the last period. There was, of course, a few situations, for example, like we can use the example of the accelerated approval for the Biogen drug in Alzheimer's, which caused significant questions that made CMS act in a certain way that we haven't seen before. And then the market reacted with a lot of surprises. And then all these are questions that societies need to always reflect on. Because again, regulators, I always say, they're not incentivized to think outside the box. If they act in a certain way and they approve something that is not as effective or has side effects, they will always be blamed for it. But if they act fast and enable something to go to the market faster to help patients that don't have any unmet medical need, they're not rewarded for that action. And it's understandable, and all these questions are important to ask from societal standpoints.
But when you think as a global investor, where you're going to deploy your capital around the world, because Qatar cannot digest all the capital you have to deploy.
Of course.
So what percentage of your investments are in the US, despite all the noise about the problems around regulatory issues? And like, where else do you think has a regulatory environment that's more friendly from an investment perspective?
So the US to us is north of 60% of our portfolio. The US is the largest market. So the US is the cradle of healthcare innovation, because not just the science is developed in the US, also the US is the largest payer for innovation and the fastest adopter of innovation. So all these things bring us to the place where the US is effectively the cradle of innovation in healthcare. And hence, I would definitely say it's the most important market by far in healthcare investing. How all these things unfold and the impact of other markets, I wouldn't say that there's other regulators elsewhere in the world. There's definitely certain areas where you find Europe can accelerate certain aspects of approvals, but definitely drug companies will always wait for the FDA approval to launch in the US, not launch in Europe. That's the story of it.
Okay. So Adaeze, as an economist, what levers are we not pulling that we might think about to unleash more capital towards this spectrum of diseases that we're all here to try and tackle?
I feel like I'm getting a hard question.
You'll get an easy one next time.
I think, when I think about, healthcare, I almost compartmentalize healthcare investing. I actually think about companies like yours very differently from how I think about healthcare IT or, some of the places where we play as a mid-cap investor, a big healthcare player, but essentially still mid-cap. Our current fund is $5 billion. Mm-hmm. Huge if you're venture, but we're not venture, we're private equity. And so we tend to, our business is primarily payer services, healthcare IT, care delivery sort of ancillary supports. And then some pharma services, but not like, hair directly. The levers I would pull there, just, our banker on the stage mentioned a couple of things that I had some responses to, but those are levers when you think about it. Differentiation, if you're building a company or you've founded a company or you're running a company, how differentiated are you from the rest of your peers in the marketplace? Easy to state, really hard to do, especially when you're in some of these spaces. Like if you're in women's health, it's really hard right now to differentiate yourself. And there's a plethora of women's health companies. Some are different. If you're serving Medicare Advantage players and you're sort of in the helping MA enrollees enroll in the right plan, pretty hard, virtually impossible to differentiate yourself in the marketplace because there's a million of them. How you leverage, first of all, how you build talent. I think one of the things we've come to appreciate and be very explicit about at Welsh is the talent. How you build your management team, how you leverage the expertise of that management team, how you build your governance around the management team. So to the extent you've got gaps in the management team, do you have complementary skill sets and experiences among the folks that you're bringing onto the board? So it's not just opportunistic, it's really strategically thought through. Co-invest, how we bring about our partners to co-invest in a deal or in an asset. Those are all levers that we pull that we think have a meaningful difference over the long term. So we don't tend to hold, contrary to what a lot of people think about private equity, we don't hold businesses for 3 years. We've got some pretty long hold periods for, at Welsh Carson, especially on the healthcare side. We do healthcare and IT, and then some overlap, because we do health IT. But we tend to think about building a company in pretty fundamental ways. So not just the services, not just the products, if that's the end goal, but really the team and its customers and stickiness across the board. So if your customers love you today, will they love you as the regulatory environment changes in 5 years? So I wear the policy hat because I have a policy background. We have, as a matter of policy, we will not invest in a company that has figured out a crevice in the healthcare system, in the healthcare payment system that they can exploit.
Yep.
That is not a sustainable model for building a business. Because I can tell you what the government can do tomorrow or next year in the next year's regulatory cycle to plug that hole. And quite frankly, if that's the value proposition of the company, that is unsustainable by definition. So we tend to think about much more durable companies that have a meaningful value proposition for as wide an array of healthcare actors, including health systems. We have deep relationships there, payers like Humana, Optum, whomever. So we tend to think very specifically about the levers and the value proposition that a company can build. Now, how does that translate on the policy side? Very differently. Because sometimes they can interpret that as something negative, something much more nefarious than it actually is. And I'm happy to be the translator. It does get exhausting sometimes, but I am happy to be the translator. How you think about building a business that is durable and sustainable is very crucial and has to hit on some of the points you raised, but some of the others that I've added.
And when we think about, Merrill, you'd mentioned a partnership with LifePoint. Are we seeing enough of that? How did that partnership come about? What are the learnings that you've taken from it? Should we all be just trying to build out entire platforms, or should we lean into other organizations that are already doing something well? Yeah,
I think kind of building on some of the comments we've heard about what's different in this environment, I do agree that on the long continuum, this is still a space that's attracting a lot of capital formation, achieving success. But I do think there are things that you need to do differently getting off the ground today that we emphasize with our businesses. I think time to ROI, you need to show real cash ROI within 3 months or you're out the door. I think in the previous environment, there was a longer, more patience for path to ROI and accepting of a more nebulous ROI, but now there's a need for cash on cash ROI within 3 months. I think the going after of kind of non-core pain points with partners, there's less patience for that. Everyone in a tougher operating environment is going to focus on what's critically important to them, and things which are a 4 out of 10 or a 5 out of 10 on the pain scale are really just not going to be worth their time and effort. So I think there's, from the building side, there's an increased focused on that effort. From the investing side, I think what you saw during the cheaper capital environment is that people built businesses that were by design more capitally consumptive. And what I mean by that is that they basically took advantage of cheap equity capital to kind of create a float between different cash flows. Yeah. So to give a specific example of that, I think a lot of the value-based care enablement platforms were made possible by the low interest rate environment. They essentially supported providers with the upfront investments they needed to make to get to a value-based world, and then bridge the gap from making those investments to when they realize shared savings via programs that the CMS administered and ACO enrollments and all that type of thing. I think that was a much needed service, and I think it did a lot of good for the country. Building that type of business model today would be much more difficult because your cost of capital has gone up dramatically. So we are now emphasizing on looking for businesses that have the inverse of that, where they kind of are able to get cash in the door much more quickly and be more capital efficient as they scale. Back to your question about how this kind of all ties back to partnerships, I think partnerships is one way to reduce your capital burn. I mean, you saw a lot of healthcare businesses essentially try to completely go around the incumbent delivery network to try to acquire patients directly, build relationships with those folks, and kind of reinvent the care delivery world. And I think there's a lot of good that was achieved by that, but it is expensive, and I think it's not always the right move all the time for every business, and especially for some of the businesses that we're talking about here that have healthcare IT, where they're trying to partner more directly via providers. If you can get that partnership earlier in the life of that company, you need to raise less capital. Your chances of survival are higher. And from our point of view, it can be a higher return because it's less dilutive.
Mm-hmm. I mean, and Eddie, to Merrill's point, coming from a years-long, essentially zero interest rate environment, the bogey was pretty low, right? So I think you can attract all sorts of investment capital to what might be perceived today as risky when I can get 5 or 6% on a treasury, depending on the day. So when you think about your space in the earlier stages, how are you attracting money into that, given that the backdrop is attractive to go elsewhere?
Yeah, I think Merrill raises a really good point in terms of, I think what we saw during the biotech bubble of 2020, 2021, a lot of very high PE platform companies that managed to attract hundreds of millions of dollars behind them, and not going to mention any names. It's obviously all great teams and interesting techs, but essentially developing what some have disparagingly kind of call a pipeline of not real pipeline programs, kind of all early stage, discovery stage programs, and I think because capital was so cheap, there wasn't the discipline in terms of really kind of going through each program and figuring out, each one of these programs, if we actually take it forward, is going to, in a therapeutics business at least, going to end up, costing tens of millions of dollars to get through and, into the clinic. So at the end of the day, is the value there for patients, and, is the product that we're considering differentiated? How do physicians and patients feel about the space? And I don't think that work was really done. And there was, again, an opportunity for exits. I think some investors did well, of course, but I think now what we advise our companies is, you can start with the platform tech, but you need to be really efficient in terms of where do you take it? What's the product at the end of the day that you're working on? And we've seen companies go through this journey many times, and Garden Health, Amir Ali, one of the co-founders, spoke earlier today, and it's a company in our portfolio that we know well, and in that case they were essentially taking the platform technology around looking at liquid biopsies, so cell-free DNA in the blood, and not an easy area to kind of innovate when they started, since tissue was the gold standard, and through kind of very sharp execution, they managed to eventually get to the stage where they are today, where now they have, I think, 12,000 oncologists prescribing Guarino tests for everything from therapy selection to residual disease monitoring and companion diagnostics, and even now going into the early screening setting.
Can I just add something, Richard? So it's important to highlight one theme I'm pulling out, I think, from the comments, how different things were just a few years ago, we can't really overstate the cost of capital. Not just the cost of capital, but just input costs in general, inflation, and the impact that has not just on investors, but on companies themselves. You now have to be, and again, established companies, we don't do seed rounds. We are looking to write check sizes of small check, 300, 300 to whatever. They're within bounds. Within bounds.
There might be people lining up after this to get some money.
$300. 300 million to be clear. What it has forced us to do, and I think you could have gotten away with this a couple of years ago, 3 or 4 years ago, is to be very disciplined about how you think about how you run that company. If you're on a payer services side, you have to be very disciplined about getting your actuarial analysis right. You have to be very disciplined about the team. You have to be, all of the input costs, because it's so expensive to do anything right now. You have to watch every dollar. You have to make smart decisions. If you make the wrong decision, because you're going to, pivoting quickly and trying to get it right. So we are finding that among our portfolio companies, our boards are engaged in this, not just the management teams, to be very disciplined and very thoughtful about the running of the company. Because quite frankly, it's separate and apart from differentiate. You got to run a company and you got to see, there's no more conversation around ROI. The time to ROI is infinite. That's just not the situation anymore. So that discipline and operational discipline is really key.
So Mike, let's think about the space now. So in private equity, a lot of these funds have a lot of untapped capital that they need to deploy fairly quickly. That might be an opportunity to merge a lot of things together. If we put a patient centricity lens on this, is Consolidated, because I know you've been involved in a lot of large scale transactions like Medline and the like, does the patient voice matter? We're talking about how expensive the capital is, how do we make it an equally beneficial outcome for the patients that are involved, as well as the financial outcomes that the companies investing are going to achieve? Do you have any thoughts on that?
Yeah, I think the patient matters tremendously in the decisions that ultimately go into what capabilities should come together, how should we design platforms to drive better experience, to drive better outcomes. I think at the end of the day, the patient centricity of that decision making is critical. I think, we touched a little bit upon the physician enablement type platforms, risk-based primary care within the context of Medicare Advantage. It all hinged on patient experience. Mm-hmm. If you really believe that more frequent interactions with a healthcare provider are going to drive better clinical outcomes, compliance with annual wellness visits, spending more time with the provider and the patient is ultimately going to enable them to pick up signals that allow them to deliver better care. You need that patient to want to spend time with their provider, to want to walk through the clinic, either whether it's a kind of purpose-built, risk-based clinic within Medicare Advantage, or it's a physician office that had capability unlocked through technology and through other clinical resources that enable folks to spend more time with those individuals. You need to see better patient experience in order to justify a lot of that investment. Now, on the larger scale side of things, look at something like Cerner and Oracle, right? You mentioned some larger cap deals. There is now, Cerner has around 40% market share within acute care hospital systems. Physicians, when it comes to interacting with their electronic medical record, there are pain points associated with that. If you could enhance the provider experience in their day-to-day interactions with the workflow tools that they need to do their jobs, there will be a trickle-down effect. They'll have more time to spend with patients. That patient will get a better experience. Maybe they identify something clinically that they otherwise wouldn't have had the opportunity to. So I think even when you move upstream from the businesses that are designed to interface directly with the patient, there are knock-on effects that ultimately are targeting better experience, better outcomes, lower cost for that individual consumer of the healthcare system.
Okay.
And just to take from there is that how this whole story comes in together is also via regulations. So for example, the one that I would use as an example is the Surprise Billing Act to address what happened with surprise billings, when you would go to emergency room in network for the hospital, but out of network for the physicians, and then you get surprise billings with significant amount. Regulation stepped in to intervene to protect the patient because this was something definitely unacceptable for these sufferings. The same aspect with the Inflation Reduction Act to try to control drug pricing because, again, the patients co-pay there. So there's a lot of things that how the patient is central to the situation is also impacted primarily by how you regulate the environment and address these situations to help the society maneuver throughout these aspects of the healthcare system and the payer system. And these regulations really impact the economics of the space. And if you're passing these regulations in certain ways that you favor one party versus the other, the economics of the space significantly impacts, and we see bankruptcies in that space, and all these things impact how investors act in this environment accordingly. And hence, brings me back to the point what I was describing as healthcare is a highly regulated sector, and hence, the more you implement these regulations in different formats, you need to be cognizant on who you're trying to reward and how is this reward going to pay off in the medium and long term, because it will impact the capital flows in that space.
And a lot of the regulation that you're mentioning tends to be payer specific, but it also is approval specific as well, right?
Yep.
So when you think about in a place like Qatar, where you have an ascendancy in things like diabetes and obesity and the like, are you thinking about, because you're the sovereign wealth fund, investing your capital to address those specific types of issues? And if so, how do you do it?
Yeah, so again, that's a very difficult question. Again, so it's kind of like back to, I would say, one of the when it comes to a regulatory situation where you had a significant unmet need, that regulations was able to address it. I would use, for example, the Orphan Drug Act back in 1984. And this is a great example where you see orphan diseases were labeled orphan diseases for a reason. Everybody knows it was a space that nobody wanted to really invest in it. And then the Orphan Drug Act was introduced. And then 20 years later, we see a beautiful success story in cystic fibrosis, where the Cystic Fibrosis Foundation partnered up with a lot of pharma biotech companies, and now we have a disease that is very much controllable. Now it's very costly to the healthcare system, but hopefully 10 years from now, when patents expire, these medications will be at a very, very affordable price to the entire world. So this kind of like the spillover effect of good R&D when it really produces something that is really innovative, that helps patients suffering. And then after the innovation cycle passes, and this is the pharma biotech contract, the social contract that they have is that they will charge large prices for a period of time. And after it, these therapeutics will be available at a very, very affordable price to the entire world. And this is, again, in my opinion, one of the most success stories. How to implement this on more widespread diseases like obesity, for example, we're seeing with GLP-1s and how this is really impacting and hopefully can potentially cause a lot of prevention of side effects that we see from diabetes and obesity in general. All these things can pay off a lot, but again, the technology that is implemented in it, it's still relatively expensive because it's peptides and it needs injection. So how you can lower it, if we can find small molecules to that space, it can actually really have a bigger spillover effect to the entirety of society. So I think these are areas, and also innovations around reducing the cost of manufacturing of either biologics or peptides or potentially cell and gene therapy. There was also another session earlier today on how we can lower the cost of manufacturing all these things. So I would definitely say we're living in the era of science that I don't think the world has ever seen such amazing innovation and understanding biology, understanding disease, having tools. So if we go back before the 1980s, the only tool we had to address disease was chemicals. Hence the alchemist, and the only therapeutics that you had was just chemical compounds. Then biologics started to be developed where we had proteins. And then a few years after that, in the early 2000s, we started to genome sequencing, and of course, Gordon, the example from sequencing costing $1 billion in the late 90s, now $1,000. You can sequence the human genome and understand biology and disease like ways we've never thought we can. And now you're having gene editing tools, cell and gene therapies, and all these approaches. So definitely there's a lot of things to be really optimistic about. The key question is that will we have the right regulations. Will we have the regulatory environment that will be enabling science to progress, while at the very same time trying to keep patients as safe as possible. We maintain the right balance from checks and balances from providers and payers to make sure the flow of economics go to the people that are providing the most benefit to society. Again, all difficult things to say. What is the right answer? I don't think I have the answers to any of these questions, but it's definitely something that makes us very excited about the future, and hopefully tomorrow will be definitely a healthier place for everyone.
One of the things you'll hear about today is another challenge is the social determinants of health. And how do we think about addressing those? How your zip code and where you were born can mean a 10-year difference in your life expectancy. Adaeze, let's go back to you. This is an easy question now. How, from an investor perspective, like when you're thinking about deploying capital, is that ever part of the lens that you're using on it? And if not, how do we excite people who are investing in the space to use that as one of the factors?
So, interesting that you say social determinants is the easy question. I'm teasing, but it is actually one of the hardest.
It poses a lot of moral questions.
It is
as
one
well.
of the hardest questions
Of course.
in healthcare because it forces us to confront the fact that when we look at the explanatory factors that contribute to health outcomes, more than 80% are actually, more than 80% of the variation in health outcomes are explained by non-medical concerns. And so we call them, I think the shorthand now is social determinants of health, but you will see, if you're in social sciences, you'll see political determinants of health, you'll see health equity often sort of as the new, more, asset-driven, if you will, asset framework in terms of communities that have something. They don't have nothing. They do have something, and so there's something from which you can build to address wide variation in health outcomes. So it is something that I think about. I don't think investors, but I'm also not a. I didn't grow up in investment banking, so I don't have this. I wouldn't say myopia, but I have a very different social science driven approach. They're not myopic. They actually think very broadly about health. I respect bankers a lot.
Would you be myopic or not?
But it is very different. It's a very different framework through which you look at a company. So going back to the patient centricity question, I hope that we would not be cited for mentioning patients 30 minutes into the session, because that we're not necessarily using the word patients doesn't mean that it's not implied. So when I think about pretty much all of our companies, but the one that I'm most intimately connected to and I'm on the board of, which is Liberty Dental, more than half of the patients served by this dental payer are on Medicaid. And so why would Welsh Carson invest in a Medicaid primarily dental platform? Because in my view, if you understand that one of the major contributors to emergency department use in this country is trouble with oral health, and that to the extent you are making a choice in Medicare Advantage, your dental offering is almost the number one issue that you'd make your decision on. And quite frankly, if you've looked at regulations around fee-for-service in the last couple of years, fee-for-service Medicare has been driving down this path of we can't just treat health and not treat oral health because they are part and parcel, part of what describes your medical sort of, outlook. It makes sense to put capital towards this because Medicaid might be the best payer in the country in terms of coverage. It is really hard to invest in Medicaid as a payer. And if we can't, we're doing our best to figure it out and to do well in this space, which is expansion of coverage. You haven't mentioned access. I implored Milken a couple of years ago to think about patient centricity beyond I have this drug or I have this therapy, that I can talk to my doctor about if if I have the most agency and I have the most money. Like, it's a very narrow sliver when you define patient-centeredness in that, through that lens. You have to think very broadly. If I have Medicaid, what's available to me? If I live in the state of Texas and I have to make $3,000 to qualify for Medicaid, what does that mean to me in terms of access? If now women's health, I'll mention it again, you know. If I am a woman in 29 states, what does health care access, whether it's primary care, what does that mean to me? And so we have to think about patient-centered and patient centricity in much broader terms than just access to medicine. So access to the most innovative, most exclusive innovations in biomedical research. Social determinants of health, once you think broadly about patient centricity, you can't escape it.
Right.
It comes as part of your conversation. So I think having smart people at the table is crucial. Having people with lived experience, of course, but also just deep thinkers on this subject. I don't think, you know, folks sort of dabble or pretend to know what communities need are helpful. I think they often do more damage because they impute much of their assumptions into questions that you know, people with much more grounded understanding, whether it's through research or through community or through care delivery, health systems, you find them quite close to some of these questions. And that could be very sort of, you know, complementary to how you think about where you deploy capital and how you deploy capital.
So Eddie, you're encountering people in the most nascent stage of their career. How do you get them to focus on those things?
Yeah, it's also an easy question for me. I think this is settings like this one where we get to kind of have people at all different points and perspectives within the healthcare ecosystem, as robust as it is, kind of coming together to think about it is really helpful because I come at, you know, what we do at Pear from a very focused lens of, you know, again, we're looking for the most kind of sharp technical founders who are, you know, experts in their spaces. They're trying to advance the technology and kind of push the boundaries of innovation there. But, you know, and you know, in some ways that's the easy step. You know, I think I saw a phrase used about kind of the human body of like, it's almost as if biology is an alien technology that just crash landed, and you know, humans have been trying to just figure it out these last several decades. You know, one piece at a time, kind of uncovering, you know, one mechanism after the next, and eventually we're going to get there because it's just the laws of like physics and chemistry kind of coming together. So I have no doubt that, you know, we'll see improvements in terms of what's possible with, you know, AI and, you know, and all the different kind of chronic diseases that, you know, we're touching on here, from, you know, cancer to metabolic and cardiovascular disease. So you know, we are investing in companies that we think in the next 10 years are pushing that boundary, but they're operating under market conditions today, and like, you know, we can't, you know, reshape the environment in which we're operating. So we know pharma companies are still overwhelmingly investing in certain diseases where they know that they can charge high prices, and you know, payers will accept that. You know, like oncology, like biologics and gene therapy. You know, I wish I see a lot of companies that are coming, you know, to us with, you know, new diagnostics, ways of, you know, engaging, you know, people in better preventative measures, tracking their health, and unfortunately, a lot of those cases, the business models, you know, the commercial prospects for these companies are just kind of not where they need to be. So, you know, I almost wish there were a way to just kind of resolve or de-risk the commercial side, so that again, some of these approaches become investable. And you know, obviously, again, the example that was brought up earlier today with COVID and the government basically stepping in and, you know, making sure that manufacturing and supply was de-risked. Like, I think there needs to be more of that kind of, and obviously the Milken Institute has a big role to play here. You know, working with government and folks in the ecosystem. But you know, until that happens, it's hard for us to kind of, as the very first step in this in this process to kind of, say that to our LPs, who, again, they may be pension funds or, university endowments, that there's a commercial opportunity today in these areas that, again, are really high and pressing unmet need.
Yeah, if I build on that quickly. I think the way we get them to focus on it is by helping them identify existing reimbursement rails to build on top of. And I think that's something that people in this room can play a role in, which is if you create a reimbursement incentive, either through a specific fee-for-service reimbursement or a large opportunity to earn shared savings, you are going to direct the innovation ecosystem towards that pain point. Prior to, misconceptions, we don't actually like taking a lot of risk. If we can cross off clinical risk, if we can cross off reimbursement risk, and I'm just taking go-to-market risk, that's something I can actually justify to my LPs that I want to put capital work behind. One specific example is we're working with Boston Children's Hospital to scale a clinical model they built for early intervention services for children under the age of 6 who have developmental delays around speech therapy or physical therapy. So they built this clinical model during COVID to provide care for children in their pediatric clinics remotely. They, through hallway conversations, learned that other pediatricians needed that. Medicaid created a payment reimbursement for this screening therapy, and now certain payers have started to offer bundled payments for people to provide care here. And we've come in, we've taken the IP that they've built on the clinical side, we've spun that out into a new company, we're investing behind it, and we're scaling that in Massachusetts, but elsewhere across the country. And it doesn't get much more social determinant than speech therapy under the age of 3. You want to talk about something that influences your life. If you don't learn how to speak correctly, quickly, you're going to lag behind. You're going to have higher instances of depression, autism, all these things. So that's about as early as it gets. And the only reason we can do that is because the payment rail exists, and we're following that payment rail.
Okay. All right. Well, I know we're almost out of time, so we've talked about a lot of the regulatory pitfalls, the cost of capital, and the negative implications of that. I want to end on a positive note. So we're going to go down the line. I want everyone to say, what is it that you're most optimistic or excited about over the next 12 months? We'll start with you, Mike.
Oh, all right. So the easy question, but quicker timing. Look, I think that we continue to see really innovative, disruptive entrepreneurs designing solutions to address big problems. And I think if that there's an overarching observation that we can be enthusiastic and excited about, it would be that. I think there are capital partners to support that innovation in various forms across the life cycle to help bring those to market. I think it's a way to kind of accelerate the excitement that we have for the growth economy in healthcare. And I think on the policy side, we do have people creating payment constructs that enable long-term durable business models that will ultimately get support to scale those ideas and to impact as many people as possible. So you kind of put those three things together, and I think there's a tremendous amount of opportunity and upside.
Okay. Mo?
So I would state again, I think our current understanding of biology and tools that we have to both address disease and treat patients is I don't think humanity has ever been exposed to this. Plus, definitely AI and bringing it how we can deliver care in a lower cost setting in a cheaper format. We're seeing that more and more we can do things in an outpatient setting, and hopefully this will bend the healthcare cost curve in certain aspects to free up some dollars to treat again the devastating diseases that we all face in humanity. So I think these are the two areas that I'm most excited about.
Okay.
I am most excited by the fact that within healthcare, we are finally recognizing the inherent complexities of healthcare. I think it is exciting because to simplify or to oversimplify a complex problem is dangerous.
Yep.
It has the illusion of doing more than you actually are, and then doing the wrong thing and breaking things further. So the fact that we're recognizing inherent complexities, which is creating a lot of noise and sort of instability in how we think about capital deployment, certainly how we think about policymaking, because you can see the struggle on the policy side. But I do think it signals that we will get it right, and we're at least heading in the right
You have
direction.
to get uncomfortable first before you can get comfortable.
We need to be uncomfortable right now, yeah.
Yeah, I mean, as an early stage biotech investor, I mean, to me, what's most exciting is the revolution that's happening in biology, where it really is kind of shifting from more of an art and something that kind of through the process of very artisanal methods, scientists, kind of probing and trying to figure out, and naturally moving towards an engineering science where all the measurement tools at our disposal from, the genomics and omics side to, even at the individual and population level, just measuring and tracking all of these data points. I think these are really coming together to, shift the field, and it's not going to be 12 months, but 10, 12 years is the time frame that these changes start to occur. And I'm excited about discussions like this one, where we can try to figure out how do we take the, the state of the art in innovation and bring it to more people.
Yeah, I would say I'm most excited about kind of the convergence of a few key trends in the entrepreneurial ecosystem. One, you have tooling, which has now been being worked on for 7 years to equip digital native healthcare businesses, and that's getting mature enough that I think it can really be valuable for the companies that are being built. You're 15 years into the post-ACA health tech innovation cycle, which means you have founders which are on their third journey. And when they've learned from those first 2 mistakes, they're going to be that much more effective this time around. And then you have similarly partners who are working at these large incumbents, whether it's insurers or health systems or people like our partner LifePoint. They've worked with enough startups that they know how to be better at this now. And I think the convergence of those 3 trends can really mean that you can start having bigger impact with some of these new things that are being built.
Great. All right. Well, I want to thank all of you for joining us here today, and thank all of you for coming.